we have evidence, where we have information that isn't being well distributed, and that we then see this kind of evolution into shock and multi-organ dysfunction. We feel helpless because we're trying to do the right thing up front, but it ends up that perhaps it exacerbates our patient's injury and illness.
Hi, long time no see. If you're listening or watching on the day this episode's out, today marks the end of Sepsis Awareness Month, which honestly kind of felt like the perfect time to announce the Sepsis Spectrum is going to be back for season 2. I'm really excited for season 2. And we're going to focus on how sepsis affects the lungs and how it affects the kidneys and what could go bad with the GI system. What can happen to our neurologic system? So we're really going to switch gears and talk about just kind of multi-system dysfunction, because we all know if we stay ahead of the game, we know patients do better. If we can identify deterioration, outcomes are much better. And that brings me to something I am really excited about. You all know how much I love these fascinating interviews we get to do on the Sepsis Spectrum. But in season 2, I'm excited to make things a little more two-sided, which means I want to involve you this season. Each episode, I'm going to read and react to some real-world cases and lived experiences that you have had with multi-system organ dysfunction. So send us your stories. They can be clinical, they can be anonymous, or even personal. Whatever you're comfortable sharing. To submit your stories or experiences, just visit www.human-content.com/sepsis. Again, that's human-content.com/sepsis. So recently, around the same time that we're recording this announcement, I sat down with my good friend and Grady Health System critical care clinical nurse specialist, Barb McLean. Barb was recently inducted as a Master of Critical Care Medicine by the Society of Critical Care Medicine for her commitment to critical care worldwide. And I just cannot say how well deserved that designation is to Barb. Because this show is all about sepsis care from various points of view, I wanted to share my own personal experience recently as a patient and how I had to advocate for myself. In addition, Barb and I are going to talk about our decades-long experience with sepsis care and how we've seen things evolve. So let's dive into a few snippets of my conversation with Barbara. I really hope you're going to enjoy this. You and I have been doing this a number of decades, and I feel in some ways things have changed quite significantly, but then in other ways, not as much. And if you were to reflect back on your career and what you've seen happen with sepsis, what do you think have been some of the most innovative changes that you've seen?
That's a hard question to answer. So let me first kind of give you my historical view. I began in critical care nursing in 1976. So this next year will be 50 years of clinical practice. And as you know, I'm still seeing patients at the bedside. I'm not doing direct care for patients, but I am still in clinical practice in my hospital and seeing patients and being a very vocal member of our sepsis committee. So I would say that first off would be the recognition of sepsis as its own entity. And for me, part of the evolution of the understanding of sepsis for me personally was thinking about sepsis as an infection that was overwhelming, to recognizing that it was a disorder of the endothelium, to really recognizing that it's an immunity disorder and that infection is part of it, but isn't the whole of it, that it's actually an immunity disorder. And really that evolution, which I think mirrors the evolution of everybody who works with sepsis, has been most particularly saying the evolution of appreciation that it's not necessarily the infection that becomes overwhelming, but the immune response and the dysregulation. And what that lends itself to kind of in our overview in our clinical practice is actually, of course, the evolution to how we are trying to identify it, and recognizing that this is not a homogeneous disease, it's heterogeneous, and it impacts and expresses itself very differently in every single person, that there's some commonalities that we certainly have gleamed onto, but that it is really a heterogeneous event, which makes it so profoundly difficult for us to recognize it universally, to treat it universally, to achieve the kinds of outcomes that we want, and even to recognize it universally or code for it universally. I think what I would probably say is I think that we progressed, but not nearly enough. And I think this next decade is going to change everything that we understand and know about sepsis, because we now have much better ways to identify structural biomarkers and really looking at structural changes that tell us that we have an immune dysregulation, and being able to do that really early, which I don't think we've been able to do.
Oh, I would totally agree. The other thing I think I'm really excited about is being able to identify what bug we're dealing with quickly, right? Versus the old school way of getting cultures, growing them on a petri dish for 48 hours and, waiting to see what bug we're dealing with. And now we're actually starting to see that we can run these rapid tests to identify from a phenotyping perspective, like what bug we're dealing with, and get earlier treatment to patients.
And epigenomics as well. So these are exciting fields that are burgeoning and growing, may not be available tomorrow for everyone at the bedside. And also this is a really high level view. It's really looking at the evolution of the understanding of sepsis. And again, I would just go back and say, I think the evaluation of sepsis and its effect on mortality and morbidity has been completely underappreciated. And that's because of failure of being able to really recognize the bugs, to look at epigenomics, to look at all the phenomenology around that, which I think is what's going to really underpin our next steps. As we look at that evolution of biomarkers and also probably AI processing, it's really going to assist us to identify much earlier. And, I think you probably know, Nicole, that I adore the kidney, and I'm the program director for CRRT in my hospital. And we do a lot of CRRT, but my goal is for my hospital to reduce CRRT by 60% because we're doing a better job of identifying patients early. And that's the same thing, I think, as with sepsis.
Well, and even like just kind of basic things that I've seen over my career is like we used to flood patients and drown them in fluid. And I think we're getting better at that and realizing that more isn't better, and we're causing massive harm. We're disrupting the glycocalyx of our endothelium. And, once that happens, patients don't just bounce back. It's not easy to just take it off, and meaning the excessive fluid that these patients are given. And I think we've just gotten a lot smarter about that and, getting antibiotics down and targeted much more quickly than we had historically. So I think that we're moving in the right direction, but I agree. I feel there's just a bit more to do.
Well, I think we would agree that early administration of antibiotics is the single most important factor. And so when I referred to that before, I wasn't saying that antibiotics aren't the right approach. I'm saying that using an armamentarium that's a hydrogen bomb instead of a really focused agenda is really going to change our methodologies in sepsis, because we need that focused antibiotic, the right antibiotic for the right bug that's been identified. And you already remarked on that and did so very beautifully. And I think that's critically important because that big H-bomb antibiotic, just big broad spectrum, gram positive and gram negative, has not actually moved us as far ahead as we would have liked. It has certainly moved us ahead. Early identification, recognition that antibiotics, timely antibiotic administration, appropriate antibiotic administration is the single most important clinical factor that we can introduce to the possibility of surviving from this terrible disorder. But I also want to talk about volume. So first of all, I think that we're doing better with volume administration because we've been dictated to reduce our volume resuscitation. But I think the real issue remains and continues to be the issue is understanding what your target is. And I think that's been very difficult for people to find a target. I know that you and I are both very avid supporters of stroke volume measures, and whether you're doing that as an arterial-based measure or whether you're doing it as a thoracic-based measure, having stroke volume is really, having a methodology for looking at stroke volume really gives us a good target. Our problem is that none of our organizations that put out consensus conference definitions or criteria are willing to say you have to look at stroke volume, because they don't want to dictate to us clinical practice that might require equipment or methodologies that everybody can't utilize. But so I think we still have a really long way to go to targeting appropriate volume. But in the 2025 definitions for sepsis that came from SCCM and the marriage of SCCM to AHA in their guidelines, the focus came off of MAP, which makes me very happy, and the focus is now on systolic blood pressure. So when we talk about volume resuscitation, we might not affect the mean arterial pressure with volume, but if we have a ventricle that accepts that volume and ejects that volume appropriately, it does affect your systolic blood pressure. So I was really happy with that criteria adjustment in this combined definition between SCCM and the AHA, which systolic blood pressure greater than 90 in a person who normally has a systolic pressure greater than 90. And of course, there's always caveats. But the other thing that I think I feel very, very, very disturbed and distressed about, and I talk about a lot, is that central venous pressure was never a volume indicator. It was always an indicator of venous distension. And venous distension is one of the most harmful aspects after fluid resuscitation. So I feel like, sometimes publications come out and they're very pithy, and really great researchers and scientists say, okay, CVP is not a fluid measure. Stop following CVP for fluid administration, which of course was always the truth. It was never a volume resuscitation. But I do think that when you have a critical patient in an ICU who has a triple lumen catheter, nurses need to be monitoring that central venous pressure, because as CVP elevates, that tells you that you have engorgement of volume in the vein. And as you have engorgement of volume in the vein, so will go volume to the interstitium, compression of your arteries, basic compartment syndrome, and of course, one of the things that I hate to see, but is a major aspect of what I do.
It's interesting, Barbara. I almost would argue that I wish these organizations would make a recommendation of using some sort of technology to help with fluid resuscitation. We know when we use stroke volume that the rates of mechanical ventilation are cut by almost half. CRRT usage is reduced. ICU length of stay is reduced. And I'll tell you, a lot of facilities I talk to, especially internationally, they say that they can't get the funding because it's not specifically in the guidelines. And, I wish that maybe some push would be made. I mean, we had guidelines years ago that said drive your CVP up to 8 to 12. And, I just wish maybe that they would. I can understand the hesitation because of what happened in the past and patients getting so volume overloaded. But I really do wish that they'd make a stronger statement about using stroke volume to guide resuscitation.
From your voice to all the directors' ears, I would agree 100%. I currently have a really good friend who 8 years ago suffered a central cord syndrome, getting up out of bed to go to the bathroom, tripped over a threshold, ended up with central cord syndrome, was a marathoner, a marathon runner, a marathon trainer, and a very effective attorney. And he suffered this central cord syndrome. And along with that central cord syndrome, he secondarily got pneumonia. He ended up with sepsis and then septic shock. He survived all of that. He's gotten some movement back in his hands, really no movement in his legs, just the ability to move his toes, not walking, but 8 years with no admission to the hospital until a week and a half
pretty
ago.
Impressive.
And he had some slight aspiration, developed pneumonia, and then went into septic shock. And just being involved with him and seeing him every couple of days, he's not in my hospital. It would be easier, then I could see him all the time, but he's in another hospital in my town. And, folks following the sepsis guidelines, or from their point of view, the sepsis guidelines, and doing 30 mLs per kg and then putting him on vasopressors. However, by day 3, his kidney indicators and parameters had significantly elevated. He was so edematous, even though they're following the fluid guidelines, because they're not targeting what they're doing. They're just following the guidelines. And I think that's one of the places that we've fallen down. Now, luckily for him, he did improve, but he had very significant pulmonary dysfunction. He had big bilateral effusions. He also had basically a pleural effusion, which got worse after he got fluid administration. So we know that our focus has become much more on antibiotics and appropriate fluid resuscitation. But appropriate fluid resuscitation is not a dictum in a homogeneous way of saying 20 to 30 cc's per kg or mLs per kg, that it really does have to be focused. And I think that's where I feel that we have evidence, where we have information that isn't being well distributed, and that we then see this kind of evolution into shock and multi-organ dysfunction, that we feel helpless because we're trying to do the right thing up front, but it ends up that perhaps it exacerbates our patient's injury and illness. And that's where I think we are as bedside providers. We're just doing the very best we can with the information that we have, but we really don't have an organization that's saying you must look at this because that is going to inform your choices.
Yeah, it's challenging, but again, I think until the organizations make a recommendation, it's going to be really hard because it does require equipment, which is a capital purchase. So I think it's really challenging. What was interesting is while we were filming season 1, I got diagnosed with endometrial cancer. And so good news is everything's okay. But, it was so challenging, I have to say, being on the other side of the bed and the bed rail, I should say. And just, I was surprised at how difficult it was to access care. And, and here I've been established with a gynecologist practice for 17 years and, and just even trying to convince them that my biopsy should not wait for 7 weeks. And I can't even imagine, I had to do so much advocating for myself. I even remember being on the phone with I jokingly call the gatekeepers of the golden door, to get into my gynecologist, i.e. the people who answer the phone. And just saying, listen, I am trying to advocate myself, because she was annoyed that I had called for the 5th day in a row. And I am trying to advocate for myself here. I saw my ultrasound. I know what my symptoms are. This is not good. And I just can't even imagine if I, who have 3 degrees and 5 board certifications, had difficult accessing care. What do patients go through who don't know the words to say, who don't know the routes to take, who just don't have the resources I have? Because I'll be honest, I'm privileged. I have really good health insurance and I have knowledge. And I have to say, it was a very eye-opening experience. The good news is that, from the Sepsis Alliance, we know now that the public has better awareness of sepsis. But it did kind of flash through my mind, what do people go through that just don't have the knowledge and know exactly what to say to be seen in a timely manner? And I'll tell you, my persistence paid off, because I did end up getting my biopsy within 2 weeks instead of 7. And I'll never forget getting the call.
So if I go back to my friend, so the first day that I saw him, he was obtunded. He was highly sedated with a high level of analgesia. He was on a PEEP of 14, and, the whole story with very significant bilateral effusions. His blood gases looked quite poor. His kidney indicators were evolving with acute kidney injury. And now there's some discussion about, are we going to put in a VAS cath and dialyze him? And I'm talking to the family. So this is a very well-educated person with very good financial resources, with a family that is 100% on his side. His wife never leaves his side. She stays with him for 13 hours during the day, and she has a person that takes care of him at home stay there at night. And she is a strong advocate. She's not a medical person, but a strong advocate. And I would say, okay, here's the list of what I want you to ask about tomorrow on rounds. If you want me to get on the phone, I will, but here's what we need to ask. And she would push that and push it. And she said, people were very annoyed with me. And they go, well, how do you know that? Are you looking it up on WebMD? So I said, no, lots of people at this hospital know me. So just say, my good friend, Barbara McLean, critical care specialist at Grady, is the person who told me to ask you. Hopefully that will help. Maybe it'll make people even angrier. But the same thing that you're saying, it's like, what is it that we as bedside providers can do to advocate better for our patients, to recognize earlier, to advocate more effectively? And as bedside nurses in particular, how is it that you can speak up and speak out without creating acrimony? And that's really hard to do. And I know, Nicole, you in your career, me in my career, we've had lots of times where people said, just be quiet. You're too smart. You're a smart nurse. You've been to too many conferences. Especially earlier in our career, maybe not as much now, but early in our career. And we're asking now for our bedside providers to take that stand, to advocate early for patients, sort of like the TSA thing. When you see something, say something. When you are seeing this and it isn't making sense to you, you start on norepinephrine of 4 and now you're on 16 and you can't resuscitate your patient's pressure. Don't keep turning it up. You need to figure out why the patient isn't responding. And that's the thing and
reassess and like you said, advocate, because we're not going down the right path if that's happening. Yeah. So we'll be back with season 2 very soon. Meanwhile, again, don't forget to share your stories and your experiences and dealing with multi-system organ dysfunction. Just visit human-content.com/sepsis. We'll be back soon. Thanks for watching. I hope you're enjoying the Sepsis Spectrum. Leave a comment below and let me know. If you want to binge some more episodes, just click that playlist right over there. And if you're feeling super generous today, give this video a like, subscribe if you haven't, hit the bell, all the things. And of course, you can also listen on the go wherever you get your podcasts. Bye.